Oh, yes.
Okay, thank you. So I will today on the association between long COVID and SARS CoV-2 serology. As you know, long COVID is a condition that is now recognized by WHO that appears in the 3 months following a documented or probable infection with multisystemic and creating symptoms lasting for months with often a serious impact on quality of life. Highly prevalent with ancestral variant between 15 and 30%, its incidence has decreased with vaccination and in the Omicron era, but not disappear. Risk factors for long COVID have been identified. First, the female sex with a relative risk of 1.5 to 2, the severity and the number of symptoms at initial COVID episode, while the role of SARS-CoV-2 antibodies remain controversial. High-level antibodies appear to be protective in some studies, while they are associated with long-lasting symptoms in others. So the objective of our study was to describe the course of long COVID symptoms after 12 months follow-up, their impact on daily life, and factors associated with improvement. This work was done in the PERSICO cohort, a monocentric prospective cohort set up since May 2020 in Hôtel-Dieu Hospital in Paris for patients presenting at the hospital for persistent or resurgent post-COVID symptoms. In this specific sub-analysis, we included only patients with a COVID episode that has been confirmed or probable for WHO and excluded those with only suspected COVID and those with severe COVID needing intensive care units. And the first COVID episode has to be between January 2020 and May 2021. When the patient arrived to month 12, we sent them a standardized self-assessment questionnaire evaluating the course of each class of symptoms, the diagnostics performed, the treatment received, the impact on social, familial, and professional life, and the change in their symptom intensity from 1, the worst situation, to 10, complete remission. And we defined significant improvement as a score of at least 8, including the decline of most symptoms and complete remission of symptoms. So about 296 patients that were at 12 months at this period, 76% answered the questionnaire. The mean age was 45. There was mainly women, as you see, a lot of patients with allergy or asthma, 25% about with a previous history of depression and anxiety, 52% who had really a symptomatic initial COVID episode with at least 5 symptoms, and only 63% of patients had a positive SARS-CoV-2 serology before vaccination. In this group of patients with negative tests, there was some patients with positive PCR, positive scanner, hospitalization, and all that. The median follow-up was 12 months. On the right, you can see the course of symptoms at initial COVID phase in gray, at the initial consultation for long COVID in orange, and at 1 year in blue. You can see that at initial COVID consultations, there was mainly hair, nose, throat symptoms and fever and cardiothoracic symptoms. And only after appear neurological symptoms, musculoskeletal symptoms, cutaneous vascular symptoms. And at 12 months, the more frequent symptoms were asthenia, cardiothoracic symptoms, neurological and neurocognitive symptoms, digestive, musculoskeletal symptoms. So here is a self-assessment of the change of symptoms by the patient. You can see that only 8.5% were in complete remission, 38.6% at the decline of most symptoms, that is 37.2% with a significant improvement of complete remission at 1 year. Among those who work, 62% had to stop working during the long COVID phase. And on those who regain work, only 32% resume full life work at 1 year, and 24.5% resume routine domestic activities. So patients are really impacted by these long COVID symptoms. We then looked at the predictive factors for significant improvement at 1 year and found that a positive SARS-CoV-2 serology at least once before vaccination, this study was performed before vaccination, was associated with a higher probability of improvement as compared to those with negative serology. While having at long COVID phase agusia, neurocognitive symptoms, musculoskeletal symptoms, skin and vascular symptoms were associated with a lower probability of improvement. And in multivariate analysis, we found the same association between SARS-positive serology and at least once, and improvement of symptoms. It was the main symptom associated with improvement, while only agusia was associated with worsening of symptoms. It is limit for neurological symptoms, musculoskeletal symptoms, because probably the power of our study was not so high. So now the immunologists usually they agree that the initial good response to SARS-CoV-2 infection is very important to prevent long COVID. And in Pasteur Institute, my colleague present 3 types of positive dysregulated immune response that can lead to long COVID symptoms. The first one is an excessive innate response, that is first excessive and prolonged, that can lead to tissue damage, sometimes activation of mastocyte and all that. The second one that corresponds to our patient with negative serology is those who have low adaptive immune response that does not control completely the virus, and there is a persistent viral reactivation from time to time. And the third one is people who have T-cell and antibody response, but that are inefficient and persistent. And those suboptimal immunity, mainly T-cell immunity, leads to persistent viral replication and tissue damage. So we are now focusing on this group of patients with low adaptive response, and presented at the CROI the first result on those patients with very specific test, more sensitive test. Here it's a S-flow test. We found sometimes in those long COVID negative patients, some patients with positive response, but the level in negative patients, here it's long COVID negative patient, is much lower than in long COVID positive and in patients with resolutive COVID. And it is the same for T-cell immunity. Those patients, long COVID patients, have a very low T-cell immunity, not completely absent. From time to time, they can respond to 1 or 2 antigens. So the limit of our study was a monocentric study performed in a single center of care for long COVID patients. It might not be representative of the whole population of long COVID patients, probably including less severe patients. And it was a real-life study. All COVID cases were not virologically proven, and SARS-CoV-2 serology, also performed in all patients, was performed at different times when the patient got to the clinic using different methods. However, we can conclude that among long COVID patients, only a minority have a significant improvement at 1 year, and that less than 10% are in complete remission. That fatigue and neurocognitive symptoms are the most durable symptoms. That a high percentage of patients in our study, it was 35%, do not have the ability to elicit detectable SARS-CoV-2 antibody prior to vaccination, and that this lack of capacity is associated with a less favorable outcome. So specific intervention targeting enhancement of adaptive immunity should be useful. The first one is, of course, vaccination, but those patients could not have vaccination. But vaccination before COVID infection has shown its efficacy to decrease in part long COVID, but it's not effective as a therapeutic tool, and sometimes reactivate the symptoms. And the other piece is early treatment with antiviral that is surely useful in case of reinfection, especially for those patients to avoid. Thank you very much.